So the reason I put together this session was seeing some morbid uses of Avastin when I shifted from an institute practice to a private practice, and even though a lot of use of Avastin are still experimental, but I would invite your comments whether you would inject Avastin in these cases. And I have personally seen these cases are from my personal archives. I have seen Avastin injected in a case of anti-ischemic optic neuropathy, in a case of X-linked retinoschisis, a case of optic disc maculopathy, and a case of central retinal artery occlusion. Of course, there may be some areas of confusion, like schisis may be confused with edema and all that, but these are the absolutely murderous uses of Avastin. The level 2 offenses, using in a case like macular telangiectasia, where there is actually no edema, and several studies, and including mactal trials, have shown that it doesn't help. Another indication which deserves a punch in the face is using it in scarred CNVM. And the more than 50% CNVM is scarred, but still there is some trace of activity in the periphery. People go on injecting, and these cases are not going to change. And finally, at least a wrap on knuckles required for patients treated for focal diabetic macular edema. We will do very well with focal, and central serous chororetinopathy, at least as a primary treatment. So this brings us mainly to the focus of my topic is abuse. A lot of my slides will be overlapping with the previous speakers by necessity, so I will be skipping over them. Most of the pictures and case studies belong to my work in Irvine and some in private practice. And the scope of the topic, the indications are rock hard evidence, which Dr. Annie has discussed. The second line treatment, I'll be discussing the cases where it can be and has been rationally used, the equivocal cases, the cases where Avastin is useless, either primarily or becomes useless, and where it is actually harmful. That is the good, the bad, and the ugly. So the scope of abuse is indications in storage and injection setting. The storage has been discussed by Dr. Mahesh already. As for indications, this is what my talk is all about, but we'll start with the area of injection. So now it's pretty well agreed upon that at least in India and probably in UK too, it's better to inject in the operation theatre under full septic precautions because ocular hygiene is frequently compromised in our patients. We commonly see blepharitis. Our outpatients have variable sterility and fomitides are universal, and OT are not as expensive in India so far. The evidence-based indications have already been competently discussed. Avastin can be used, or anti-VEGF can be used as second-line treatment to laser photocoagulation, like in BEAT ROP study has shown. This Dr. Jinder has just discussed, so I will not stay upon that. One of the areas where Avastin has been game changer is rubeosis and rubeotic glaucoma. Dr. Jinder also talked about it. This one point I want to re-emphasize, that this has led to a dramatic salvage of some eyes which are considered hopeless before. So when we combine laser with Avastin, we are able to recover not only the eye but also vision in a lot of these cases. But we have to remember that all the rubeoses are not the same. The rubeosis because of ischemic vein occlusion are the worst as in terms of the eye salvage and vision is concerned, followed by ocular ischemic syndrome, followed by PDR, and probably the best case scenarios yields these, though I have to agree it rarely give rise to NVI or NVG. They have been used in case of inflammatory macular edema, though there is some rationale for using Avastin in these cases, but actually probably there is more rationale to use corticosteroids in macrovascular edema than to use Avastin for inflammatory edema. So it should always be a second line treatment. To count further, it can aggravate ERM formation because it is angiogenic, especially Avastin. It has been used very competently in polypoidal choroidal vasculopathy. Now, just to put what Jitendra has already said, we are not aware that actually a lot of us, our population has, which we call exudative AMD, especially occult exudative AMD, are actually PCVs. There is no study from India so far, but studies in China, Japan, Korea, everywhere have shown that 25 to 50% of the presumed exudative AMD are actually PCVs. So it is, in these cases, PDT is the treatment of choice, and Avastin or Lucentis can be a useful adjunct, especially in case with extensive disease or with RP atrophy. Another area where Avastin has been a game changer is in vitrectomy, as a adjunct to vitrectomy. Now, if you look at the cases here, this case, in these cases were considered inoperable some time back. You cannot even figure out if this is the right eye or the left eye. The disc is not seen. So these cases, thanks to Avastin, have become operable now actually, and this has been proved recently by the meta-analysis of the various trials, as Dr. Annie also mentioned, that it reduces intra and post-operative bleeds, helps in membrane dissection, and reduces surgical time and complications. Now let's come to the more shady areas. It has been reported, and I agree that it can be used in diseases like Coats disease, vesicular tumor, retinal artery mechanism, and what I'm talking about, central serous core retinopathy. As far as CSCR is concerned, my stand for Avastin has changed from absolute contempt to cautious acceptance. There have been several reports and at least 3 controlled trials which says something about the validity of Avastin in central serous core retinopathy. Though most of them decline to support it, they all agree that it should be used only for chronic CSCR in cases where photodynamic therapy is unaffordable, and Quinn et al. Have shown, and at least Dr. Dinesh Talwar also agrees, in cases where there is a lot of subretinal fibrin, in these cases Avastin probably has a role because PDT may cause more scar formation. Now, retinal artery mechanism, now it's a disease with a variable natural history, whether it can resolve on its own, but not always. So Avastin can help to hasten the natural recovery. So that's what it does. So we have to know what is good for, and especially in case of macular edema, it probably improves the visual recovery prognosis slightly, but it is not proven yet. I have personally used Avastin in some of these cases, and there are several reports, small and large, on Avastin coats. A word of caution here is Avastin does cause some fibrous tissue formation, and it probably is not always complete on its own. So in this case where you have a huge subretinal exudates, we had a substantial resistance from Avastin, but again we had to use intraretinal steroid to complete the process. We had to use cryo laser in the peripheral telangiectasia, and we had to drain the detachment to get an excellent result later on. So it can be used as part of the spectrum of treatment. Similarly, in vesicular tumor, in this case, I have used Avastin with good result. But again, this case required intraretinal steroid injection to take care of the hard exudates. Now let's come to the equivocal use of Avastin or anti-VEGF drugs in general. We have to remember that all the randomized trials have actually enrolled patients with a vision ranging from 612 to 3/60, as Dr. Annie pointed out. So there is actually no evidence for injecting in patients who are 6'6" or 6'9" or 6'6" part. Second thing is, as Cochrane database reviews, who have taken a meta-analysis of all the big trials, they have said that up to 66% of the eyes on monthly regimen for 2 years, they only maintain vision. So 66% of patients only maintain vision. So what it tells us is the patient already has a vision of 3/60, there are 70% chances that he will remain 3/60 at the end of 2 years, and after losing about 2 or 3 lakhs of rupees in Avastin or Lucentis. And actually we don't do monthly injections for 2 years, so PRN did actually worse. So this is a sobering data we must know. Finally, the natural history data from the Marina study, which is not as highlighted, which I feel like highlighting again and again, is for an occult CNV with a stable vision of 612 or better, 95% chance that it will maintain the status quo, and therefore no treatment is required for an occult CNVM in an exudative AMD if there is no recent worsening clinically or angiographically. Now let's come to when Avastin or anti-VEGF is absolutely useless. If we go on injecting and the patient remains unchanged after 3 to 6 shots. Now the opinion differs. Dr. Ayalo personally spoke in our symposium, and he said that after 6 injections, but most of the Indian authors believe after 3 injections, we switch to other anti-VEGF, and if that doesn't work, we shift to steroids. So we should not keep on injecting the drug forever. We have to keep a sobering point in mind that in BOLD study, half of the non-responders improved much later. DME with significant subretinal fluid also responds poorly and probably responds better to intraretinal steroids. And when the vision starts worsening instead of not improving, then probably we can consider changing after 1 injection. A more important thing is to stop injection when the CNVM becomes predominantly scarred. This is a point which is not clear to people generally, that when the central area is completely scarred, a few blood streaks in the periphery, even if they show some activity on angiography in the periphery, do not merit treatment. Similarly, cases with extensive retinal atrophy also do not deserve treatment. Other futile indications are Macular telangiectasia, as I have already shown, which has no edema, only atrophy. We now know that it is not a vascular disease, it is actually a neurodegenerative disease. Similarly, though Avastin came from the systemic use on tumors, we know that in all the tumors of the eye, especially the vascular tumors of the eye, it does not help. And this also has been well shown. Finally, for diabetic macular edema with focal CSME, now if the CSME does not involve the macula, or if it involves the macula only minimally, or if the vision is 6/6 primarily, then there is no logic in doing this, because in these cases the ETDR guidelines that laser can maintain vision apply perfectly. In fact, a recent DRCR study has also shown that in these cases laser should be the first choice of treatment. We already know that when there is vitreomacular traction, it can be aggravated by the use of anti-VEGF. And it can be aggravated to the extent that if you have a case like this can become like this. So I have personally seen a lot of unfortunate cases of vitreous hemorrhage which have gone on to develop tractional detachment because they were given Avastin without telling the patient anything about the need for surgery. So in a case with fibrovascular traction in a PDR, or in a case of frank vitreous hemorrhage, both in EELS and in PDR, it has got a very doubtful role. In some conditions of non-ischemic AION, it is actually known to aggravate the AION, so it is actually absolutely contraindicated. And similarly, there are some conditions like uncontrolled diabetes, blepharitis and conjunctivitis where no injection should be given. But it's time to address an old fear also. Does chronic anti-VEGF treatment, for 1 year or 2 years worsen the retinal ischemia? It does not. According to the most recent evidence from the ophthalmology journal, and from the previous journals, mainly by Campochiaro and colleagues, the VEGF blockage actually suppresses the formation of capillary dropout areas, and therefore we can use these Avastin or anti-VEGF drugs fearlessly in the cases of retinal or even macular ischemia. Of course, it doesn't need re-emphasizing that in AIUN, CRO or SCISIS completely avoid this treatment. So to summarize, when there is a vitreoretinal traction, irrespective of the etiology, please do not use any anti-VEGF drugs unless the need for vitrectomy has been explained in surgical cases and surgical skills to handle the tractional complications are available. After the Avastin, the surgery should be followed within 3 to 7 days. We should avoid any indication other than the retinal vascular or microvascular diseases which cause macular edema or detachment or new vessel formation. The tumors do not respond to Avastin, though it may help to ameliorate their secondary effects like macular edema. For vision less than 3/60 or better than 6/9, anti-VEGF drugs are completely untested, and therefore this dubious risk-benefit ratio must be completely justified to the patient before trying this. It should not be used for fovea-sparing macular edema, where focal laser still is standard. We can inject as long as the patient responds, but we should switch when there is a lack of response after 3 to 6 injections, or there is worsening after even 1 or 3 injections. Finally, we should combine with focal treatment as been shown by Dr. Jatinder as soon as possible, at least in diabetic macular edema and vein occlusions. Thank you very much.